Okay, so next is the renal trauma V14. A 28-year-old male is admitted following a road traffic accident. He is initially unstable, however, responds to the fluid resuscitation. His CT imaging shows a likely splenic injury and large left perinephric hematoma. Describe the anatomical relationship of the left kidney. So, left kidney anteriorly is related to the stomach, duodenum, pancreas, spleen, and the descending colon, and superiorly the kidney is related to the adrenal gland, and posteriorly the relations of the both kidneys are the same, consisting of the diaphragm, quadratus lumborum muscle. The hilum of the kidney lies over the psoas muscle. The subcostal vein, artery, and nerve lies behind the posterior surface of the kidney, in addition to the iliohypogastric and ilioinguinal nerves. Describe the blood supply and the course of vessels supplying the right and the left kidneys and their relationship to each other. The renal arteries arise at the level of second lumbar vertebrae from the lateral side of the abdominal aorta, immediately inferior to the origin of the SMA. The renal arteries are approximately 4 to 6 centimeter long and run in a lateral and posterior course due to the position of the hilum. They run posterior to the renal vein and enter the renal hilum anterior to the renal pelvis. The renal arteries divide into anterior and posterior divisions before entering the hilum. The renal artery also supplies the adrenal gland and the ureter. The right renal artery originates from the anterolateral aspect of the aorta and runs in an inferior course behind the inferior vena cava and the right renal vein to reach the kidney. The left renal artery originates from a slightly higher and more lateral aspect of the aorta with a much shorter and more horizontal course than on the right. Venous drainage is through the renal vein which drain into the inferior vena cava. The right renal vein is much shorter than the left. So left is the long. That's why the transplant surgeons prefer the left kidney. What structures may you need to divide in a nephrectomy? So it's renal artery, renal. Let's start from anterior to posterior. So it's a renal. Renal vein anteriorly, then renal artery. Renal vein, renal artery, renal pelvis. So left renal artery, left renal vein, left ureter and gonadal veins. What are the principles of exploring a kidney in trauma? A middle incision from Zifi to pubic. Early vascular control. However, for renal injuries that do not need nephrectomy, when dealing with the associated splenic injuries, the retroperitoneum should not be opened to preserve the tamponade. If nephrectomy is needed, the transverse colon is lifted upward with the exposure of retroperitoneum performed by lifting the bowel spirally and to the right. A vertical incision is made over the retroperitoneum, overlying the aorta, superior mesenteric artery, and into the retroperitoneum and extended upwards to the ligament of Treitz. The left renal vein is identified, crossing the aorta, and can aid in the identification of the remaining renal vessels. Loops are placed around the vessels which are left unoccluded unless heavy bleeding is encountered. The artery is occluded first, and if bleeding persists, the vein is clamped to reduce the back bleeding. And the retroperitoneum lateral to the kidney percutaneous can then be elevated midly to expose the kidney. And what is the preoperative imaging vital before exploring renal trauma, and what modality suitable? Ensuring that the renal kidney is present and functioning, although a CT scan with triple phase is ideal. Patient undergoing laparotomy, then an on-table IVU can also be utilized. Thank you.